Welcome to the Queens of Moxie. I'm Mary Kay Campbell, the host of this program, and I'm so excited that you've decided to join us today. Every week, we bring amazing women to our podcast to talk about how they have stepped into joy and reclaimed their moxie and are living their authentic life. I want to get started, but before we do, I want to remind you to subscribe to the weekly email. Simply go to queensofmoxie.com and click on Weekly Inspiration. That way, every Monday morning, you'll get a link to the latest podcast, a beautiful image, and a fabulous quote. It's a great way to start out your week. So let's get started with today's podcast. We're here today with Kim Rogers, and we are talking about a really important topic. And it's something that I think a lot of people feel uncomfortable about. I don't think it's talked about enough. I feel like it's taboo in some ways. And for me personally, I had no idea that it was so common and that there were ways of treating it. And so I'm really, really just so grateful that Kim has taken time out of her schedule to meet with us today. And before we get started, I want to give you a little bit of information about Kim. She is a physical therapist and she focuses specifically on pelvic floor issues. She went to the Ohio State University for her undergraduate in health sciences and got her clinical doctorate of physical therapy from the University of Toledo. And she is joining us here today from Ohio. And I'm lucky enough that I was a patient of Kim's. And so I got to talk to her and learn a lot more about what her background is and what she's done. And I can't begin to tell you how grateful I am that I treated this issue for myself. And so today we are talking about female incontinence. And for me in specific, it was stress-induced, which means that when I would jump, when I would laugh, when I would sneeze, when I would cough, basically live, I would leak. And as I got older, it got worse. And it got to the point for me where 2 Thanksgivings ago, so not this year, but last year, I was sitting around the table with my family, laughing hysterically. And I laughed so hard that I soaked through my poise pad, my panties, my jeans, not once, but twice. And it was enough for me to go, okay, enough. There's got to be a better way of dealing with this. And so, Kim, I am so grateful that you are here today and that we are going to shed some light on this topic. So welcome.
Thank you. Glad to be here.
I'm glad to have you. I really am.
Yeah.
And so I want to start out talking about physical therapy and specifically dealing with pelvic floor issues. I don't know that a lot of people know that this is a specialty. So tell us a little bit more about it.
Sure. So being a physical therapist, we can, of course, treat the whole body. And that's what we're taught in our education, earning our clinical doctorate. We are taught about the pelvic floor in our education, too. However, it's pretty much just kind of very surface level. We're given just a little bit of information of here's the floor, here's what it does. If you want to know more, you're going to have to learn more when you're outside of school. So typically a therapist that does treat pelvic floor dysfunction has additional education, usually through their continuing education, to learn more about how to examine and treat pelvic floor dysfunctions. And that encompasses a lot of different diagnoses and issues beyond incontinence that we'll speak a bit more about specifically today. I am trained through the Herman Wallace Institute of Pelvic Health. There are different companies and venues out there that do help to educate therapists and even other clinicians as well. So it's not just for physical therapists. There are occupational therapists, chiropractors, nurse practitioners, different professions, and then those different venues will tell you who is appropriate to learn what under your jurisdiction and also what your scope of practice is. So I learned through them between the years of 2019 until 2021. And there's a lot to learn. So there's multiple courses, but basically you learn a bit more specifically on how to help this kind of more unique niche of clientele and issues with pelvic floor dysfunctions. So I began in that journey and I've been loving it ever since. And it's been a really, really rewarding profession to be in and to especially treat that kind of clientele.
So tell me, I came to you because of stress-induced incontinence.
Mm-hmm.
And, I had one baby that was almost 9 pounds and another that was over 8.5 pounds. I'm 50 years old. As much as I hated, I'm overweight. So I think there are a lot of factors that contributed to my stress-induced incontinence. But
Sure.
we're going to talk about that a little bit more in a bit. But tell me some of the other concerns that some of your clients have when they come to you.
Yeah, so as far as pelvic floor dysfunction goes, we most commonly do see female population, and that includes urinary incontinence. We also can experience fecal incontinence as well. So we're not just limited to just one end, it can be both.
Oh dear.
We also will see many women postpartum to help with recovering from either C-section or vaginal birth. Additionally, we'll help with pelvic pain conditions. So some people just have pelvic pain generally throughout their day. For some, it's provoked by things like intercourse, which is called dyspareunia or painful intercourse. Some people have pelvic pain trying to insert something into their vagina. Would that be a speculum for an exam, a tampon? And some people have never been able to do that. Additionally, we can also see people for constipation, which we often maybe don't think about. Some people do need help with being able to evacuate their feces more effectively and avoid that strain. We can, of course, see some people too after certain surgeries. Maybe there was a traumatic injury or accident, or maybe they did have some type of urethral sling surgery or mesh or something to help with pelvic organ prolapse. And additionally, we do treat that conservatively too, the pelvic organ prolapse. There's kind of different things that you wouldn't believe exist out there, but that's kind of the gist of what we can see and treat most commonly. Every once in a while, you get a curveball of like, I never thought I would see this in my career, which I've had happen just a handful of times in the short amount of time I've been doing this. So it's interesting what can happen to an area that really has a lot of function to it when you think about it. So we certainly have in our pelvis the ability to keep things in or out, such as urine or feces. The floor does help us to participate in intercourse as well. For females, it can also help us to birth a child. And then additionally, we don't think about this, but our pelvic floor is part of our core. So it's a foundation muscle. It can help with our breathing and also with our balance. So it has a lot going on in that area. So you can imagine if one thing is dysfunctional, how that could impact many other parts of our function as well. So oftentimes we don't see just one issue of, oh, I'm leaking. There might be something else going on in addition to that. And there are several factors that contribute to those beyond just the floor itself. So as you had mentioned, you're like, oh, well, I have extra weight on my body. Certainly people that have more weight sitting on top of their pelvis can have more issues sometimes. Even things like breathing conditions, if you have COPD, if you have a chronic cough or any type of issues, that's a lot of pressure in our abdomen over time that can stress the pelvic floor too. So we often don't think about kind of holistically how our whole body can influence what's going on in the pelvis itself.
Yeah. Well, it's interesting because I have asthma, and so I
Sure.
cough a lot,
Right.
a lot. And as I've gained weight, my asthma has gotten worse, so I've coughed more.
Sure.
And so one of the things that happened with me, to give people some background, so I noticed a little bit of incontinence, stress-induced incontinence, I don't know, 8 years or so ago. And I went to my gynecologist, and so she gave me a pessary, and for those of you listening, it's basically something that you insert in the vagina, and it pushes it pushes the urethra or pushes the bladder up?
So it depends. And your situation was probably the urethra and or bladder, but it's meant to kind of post whatever's coming down into place.
Yeah. And it worked for a little bit, and then it stopped working, and then I just kind of was like, whatever. And I just wore poise pads because it wasn't that bad. But as I got older, and as I gained some weight, and as my cough got worse, it continued to get worse. And I came and I saw you, and I had made an appointment with your gynecologist months in advance because specialists, you sometimes have to wait a while. And so in the middle of our treatment, I went and saw the urogynecologist. And this is really what happened with me was like, okay, so and people listening are like, I can't believe Mary Kay is revealing this much personal information. But again, I feel like it's really important to pull back the veil and to talk about it. And so
Of course.
my pelvic floor is strong, and my core is very strong. I was a gymnast, and I have a pretty strong awareness of my body, and the muscles and what things are doing. And I can isolate things probably better than the average person, just because of my gymnastics training. And there's a rating for your pelvic floor strength, and it goes from 1, up to 4. And when I went to the urogynecologist, I was at a 3. And she put a different, so what had happened is my pessary had gone up into my vaginal canal. And she said, let's try a different shape. So she tried a different shape. And she had me go in the bathroom and put a Chuck's pad down and said, I want you to cough without kegling. And I said, really? And she said, yes. And I was like, oh, this is not going to go well. I coughed and it was like I peed. And I was like, oh my gosh. And I went out and I was like, yeah. And basically what she said is, you're at a 3, we can maybe get you to a 4, but you're always going to have this problem. And what I realized was that my kegels were working, but it was that sustained, constant need for them to stay contracted to keep everything where it should be because of my cough. And so I opted for a surgical solution for this. And I absolutely believe that everyone should try all the other options first, and that it can be hugely successful. And that's what you do, all the other things besides the surgical aspect of it.
Sure.
For me, and I've told you this before, Kim, the surgical option was life changing for me.
That's awesome.
It was truly life changing. And so I had the urethra sling, and it holds everything where it's supposed to be. And I will never forget, I went to a soccer game for my youngest, and the moms were laughing on the sideline because there were just some antics going on the field that were just funny. And something happened where someone on the other team called out the ref, who was a teenager, for not calling something. It was a co-ed league, and this guy like flattened this girl, and she was like lost her breath, and the ref didn't call it, and the other team's girl said, hey, she's on the ground. And we just started laughing hysterically, and I was laughing so hard that I started coughing. And normally I would have totally wet myself, like I would have had to go to the car and change, kind of thing. And I didn't leak at all. And I was just amazed. I was like, oh my gosh, my life. And I don't wear a poise pad now, and I laugh all the time, and I still cough all the time. And oh my gosh, it is truly life changing.
Sure.
So I know that this can make a difference, and I'm just so grateful. So talk about what you do for all the different levels of the incontinence part of it. Now, I do, before we go there, I have to say, like, when you're talking about the kinds of things that you treat, I think most people would go, wow, that is unusual. That's and so I have to ask, like, why did you decide to move into this specialty?
Sure. So I think a part of it comes from basically the kind of foundation of your podcast here is that it's women's empowerment, a bit more driven from that regard. Kind of just some life experiences, including some traumas, both in healthcare and in my social life, just made me realize that we need to do a better job supporting women in their bodies and in their minds. And I think too, just being a healthcare provider, I found this to be a good avenue because I knew pelvic health was a relatively underserved population of people that have dysfunctions because it is such an intimate area. But there is so much to be learned, and that's also why we're having this podcast today, is to tell people and kind of bridge that gap of information that's not there, to let us know that we're not always stuck with what we have, that there are tools to help us with whatever is going on. So that was a way for me to kind of realize that I really want to do a better job supporting women throughout their lifespan. Not only in my social life where I did some self-work there, but to just kind of, I was like, I might as well turn this into something positive in my profession as well. And additionally, I had my own experiences in just the healthcare field where I realized that clinicians don't always share all the information that's out there to help us with certain conditions, nor do we always know what's going on. And I think it's a bit discouraging or disheartening when we do experience something that we know there's something wrong with our bodies, and people either say, well, the image doesn't show anything, you're probably fine. Or
Yeah.
they see the emotional distress and think, oh, poor thing, it's just the stress. And there's so many things that I think just kind of get placed on a condition that's only a piece of the puzzle.
Right.
What I love about being a therapist is we try to put all those pieces together. Now, certainly we do focus on kind of the more physical piece,
Right.
but I really like to treat my patients more holistically. I've kind of developed that over time because you realize you can't just treat the one area. There's so much more to it. Mentioned with your condition, you have this chronic cough going on. Certainly I can treat your pelvic floor. Certainly you can have the surgery, but maybe the cough needs to be addressed even better, as one example.
Right.
So to without going too far in depth, it really was just something that I felt compelled to do from a very, very deep emotional standpoint, from just things I experienced where I'm like, I can turn something negative into a positive, and this is one way, and I can support women even better
Yeah.
with what I do now.
Yeah. Yeah. So, well, thank you.
Sure.
Because I think this is something that is difficult to talk about. It's difficult to bring up. It's something that is so deeply personal, and
Sure.
you're doing a pelvic exam. I mean, like,
Mhm.
it's a really different kind of physical therapy than if you sprain your
Sure.
ankle.
Sure.
Um,
Absolutely.
and I've done both, so I
Yes.
know. Um, and so, I think that women can really appreciate the fact that there are clinicians like you who are doing this because of this deep longing to help others and
Sure.
this desire to help women through this process, whatever it might be, whether it's
Sure.
trauma induced, whether it's a physical aspect, whatever it might be.
Sure.
So tell us about some of the things that you do uh, for your patients to treat the variety of things that you have going on, or that patients have going on, rather.
Sure. Well, I think upon meeting anybody, we want to know their story. So I'll oftentimes see the prescription or refer, or sometimes they do come to me because they know pelvic therapy exists and they're like, I found you on the internet, so I brought myself here by myself, which is great. But oftentimes we'll just see a diagnosis of, stress urinary incontinence as an example. And I'll tell people, okay, this is what your clinician said, or this is what you put on your form. But I will tell people, just like, tell me your story. What brings you here? And I just kind of let them go on their tangent, because I think what everyone tells me is very important. And sometimes people will say, well, this probably doesn't matter, but I had this happen. And I'm like, that very much matters.
Yeah.
And I think they almost they think they have to dismiss something because to them it sounds like, oh, this is probably insignificant, or they've had someone else tell them that that's probably not a thing, when it definitely is. So we get their history of just what's going on. And then again, from that holistic approach, I want to know what's going on with their whole body. So we, of course, review what kind of other conditions do you have going on. As we talked about how those things can influence pelvic floor function too. Again, going back to your example of asthma as one. And then we go through an exam. Now, the exam depends on the person, what they're comfortable with. Oftentimes, the big thing is to examine the pelvic floor itself. That's kind of what they're there for, is to see what is going on with the muscles in that area and the structures in that area. We oftentimes focus a bit more specifically on what are the muscles doing, but of course we have nerves, we have the bones there. We can look at certain positions and how people present with their posture. But when I do a pelvic floor examination, I usually offer the patient two options. I do pretty much immediately tell them, like, hey, we do have the option to either do a transvaginal examination or transrectal examination. Depends what they're coming for. Oftentimes for a female, it will be transvaginal, but for my patients that do have fecal incontinence, we're going to go the other way. But I tell them why that's important. And really, the idea is to get a direct view of what is happening in these structures. Think about if you've ever gone to a doctor and you're like, oh man, like I got this pain in my neck and it just won't go away. And you're sitting there touching it. And like, how often does a doctor actually come to touch you? Sometimes they don't at all. They just sit there and listen. And some people actually want to be touched. They want their clinician to feel what's happening. Now, certainly in this area, that's a bit more personal, definitely more in your space, but it does give us the most direct information information of what are these muscles doing? So we can feel internally, can I feel those muscles kind of squeeze around my examining finger? Can I feel tightness there? Or is there a lack of tone? Can I see that there's some laxity? So almost like the either vaginal walls are collapsing, and that could suggest some pelvic organ prolapse. Or can I tell that you're just very guarded and tense? There's so many things that we can find by just feeling. And certainly we can also, as an alternative, feel over someone's clothing, where I tell someone, I'm going to touch at your sits bone, walk into some personal space, and we can feel the muscles over clothing. However, that doesn't give me the best impression of what's going on, because my fingers over clothing can't sense as well. And sometimes I'm like, I'm pretty sure I feel you contracting, but my sense could be wrong.
Right.
And I wish I could say I'm perfect every time I do an exam, however I do it, but not always.
Right.
So that can give us kind of a quick view of how that muscle is doing by kind of just feeling over clothing, and everything's with that patient's permission. And then oftentimes as we get to know each other, if there is somebody who's like, I don't want to do a transvaginal exam, they're eventually like, okay, I do want to know more. And they get this curiosity, which I think is fantastic. I think it is actually very empowering for someone to be kind of walk through, like, here's what your muscles are doing, here's what I'm seeing, and how that affects your condition. In addition, we'll also just look at how does a person move as a whole. So we look at kind of their whole spinal movement. We look at their breath pattern. I talked about earlier how we don't really tend to know this, but our pelvic floor does help our breath mechanics and how we breathe. We also look at overall core. So our pelvic floor does work with other deep abdominal wall muscles. So just looking at the abdomen integrity itself, even of course the hip structures around the pelvis, since we know that the hip bones are directly right there with the pelvis itself. So oftentimes we might treat other problems we see, because it's part of that whole picture of what's going on top of the pelvis, around it, below it. We often can't just focus on exclusively the pelvis in itself, but we want to know as much information there. So we do that exam a bit more specifically to that area. And then depending on what the exam findings are, so let's say it's weakness, maybe say there's some coordination issues where the muscles just don't fire when you cough or sneeze, we treat you that way. So I'll be like, okay, so you are appropriate for Kegels, but this is, you need to work on your endurance. You're going to do a Kegel and you're going to try to squeeze and hold it for a longer amount of time, not just sitting there and squeezing and letting go all day long. You're going to do it for this many repetitions, and here's why, because research says this many. I might be like, okay, next time you cough or sneeze, you need to do a Kegel to help tell your body to help hold that in. And as you experienced with your exam where your doctor said, don't Kegel, you realize what happened when you didn't. Okay. Yeah. So sometimes it can be some simple fixes like that, where it's like, well, if you just control the muscle movement better, that helps to resolve some things. And then just depending on what the person's coming for, it might go beyond, of course, the pelvic floor, as I mentioned, and we might work on strengthening the upper core, work on their breathing mechanics, working on their timing of firing muscles. So that can come with just various exercise techniques, strategies, depending what I find is appropriate. There's also little devices or tools that we can use to help strengthen pelvic floor more specifically, or help to re-educate the movement. So we have some devices I'll just kind of throw out there, like vaginal dilators, to help with either feedback or stretching. There are Kegel weights that are little weighted, almost like weighted tampons that can be inserted to the vagina to help more with kind of functional training and strengthening of pelvic floor muscles. There's even something called biofeedback, where we can use a little machine to put little patch sensors either around the perineum, which is the bottom of that pelvis area, or either an internal sensor in the vagina or rectum. But those little stickers or probes help to read muscle activity, and the patient can actually see that being put on like a little map on the computer, and then they can kind of see when they Kegel how much does their muscle react or contract, and when they relax, how much can they get to relax. So it's a more visual way to retrain that muscle group depending on your goal. I think that's kind of as simple as I can put it. Considering that there's so many different avenues depending on what you're coming for, but those are some common things you might hear or see or explore with your therapist.
Yeah, I mean, I first learned about it, I was working at UVA Health System in the medical center marketing department. And this was probably 15 years ago. And we were rolling out a program about pelvic floor. And I wasn't the one working on that particular campaign,
but a friend of mine was, and that was the first time I heard of it. And at that time I didn't have any issues. I didn't, I was like, oh, okay.
Sure.
And I kind of went on. And then when I started having issues, I was like, huh, okay. And like I said, as a former gymnast, I have a strong core. I've been Kegling.
Sure.
But what I found very interesting when we met is I was Kegling wrong all of those years.
Sure.
And I had no idea. I think what I did probably still helped, obviously, because I had a 3 out of a 4. But
Mhm.
can you explain to the women listening here today, how do you do it properly? Because it does not involve your gluteus maximus at all,
Correct.
which mine totally did before. So
Yes.
explain to us what that looks like and how you can control that.
Sure. And I think this is really good to go over because for some of my patients who, for example, don't want an internal examination of their muscles, I have to figure out how do I tell them how to Kegel correctly without being in their space. So oftentimes for a female, it's I think a little bit more advantageous to teach them because we have a bit more orifices in that area, and we're used to inserting things into the vagina, for example, either for menstrual hygiene, for examinations like a gynecological speculum, or even for things like intercourse and intimacy. So oftentimes what I'll tell women who are struggling is I tell them to think of like their sitting on top of something small, so maybe like a blueberry, something that's gentle and that you wouldn't want to really squish. And I'm like, okay, so you want to think about trying to use the muscles just around the vagina to grab onto that blueberry and then gently lift it up into your body. And I'll try to kind of use my hand signals to kind of tell them like, here's what I want you to feel, and kind of try to show them something a bit more visual. Or I'll tell them like, think about there's a weighted tampon. Someone tells you to stand up. They want you to hold on to that tampon. Don't let it fall out. You have to grip onto it and gently lift it up into your body. And you want to feel that effort come from the muscles that are at the bottom of the pelvis. So specifically around like the vagina and rectal area. You shouldn't feel like you're squeezing you're clenching your butt cheeks to do that. You shouldn't feel your inner thighs shake or twitch, or your inner thighs tense up. You shouldn't have to hold your breath. That's a big one. And you shouldn't feel like you're having to almost like push or bear down to do it. Some people will kind of pressure out to try to Kegel. It is okay to feel a little bit of lower abdominal contraction. So that's the one thing where people are like, oh, I can do it, but I feel my lower abs kicking in. I'm like, that's okay, because those two muscles work together. So that's kind of often a description I'll go for to help females kind of figure those muscles out. And it depends, y'all feel over their clothing what's going on. And I kind of see how's their body responding to those cues. Sometimes we're very successful. Sometimes we have to keep going through like different things of like thinking retraining to make it fit in their brain, because not everyone responds to the same thing.
Right.
And that's part of our job as a therapist, is to help people figure out like what's going to facilitate your muscle movement or down train it depending on what the goal is. One last thing I'll teach women is thinking about a little elevator shaft sitting in their pelvis. So if they really need to figure out how to contract their floor but also bear it down or relax it, I tell them to think about a little elevator shaft sitting in the pelvis. When we're at rest, not doing a Kegel, the shaft is just at ground level. When we contract and lift our deep floor, we kind of feel like a little gentle pull up and in sensation up into the pelvis. And then when I tell them to relax, they go back to ground. When I tell them to bear down, it's like you're sending the elevator to the basement. We're creating a little bit of a bow down pressure. And that can be a nice visual guide for people to be like, oh, I see. Like when I do Kegel, it feels like there's like a lift sensation. When I go to the basement, I can feel like there's a little push down, like it would go to the basement. That's like one of my favorite ones to use, is that little analogy there. It's usually pretty receptive.
I was surprised by how subtle the movement was for the Kegel. I was stunned. And I've talked with some friends about it. I'm like, we have been doing it wrong, y'all. And they're like, really? You don't involve your butt cheeks? I'm like, no. It's a very subtle movement. And
yes.
I've always been one, okay, I'm at a red light. I'm going to hold it until the red light passes. And like, because otherwise, I don't have like a specific routine. So that's my deal. Like when I'm driving, I'm not doing other things, and I can remember to do that. Yes. But I was surprised by how subtle the movement is. And also, as I started talking to other women about having this issue and getting this surgery, I was stunned by how many women have this issue. So can
Sure.
you give us some of the information on like, and I didn't ask you for this before, so you may not have the
Sure.
statistics, but like
Yeah.
how many women encounter this? And I'm guessing the number is probably significantly higher because a lot of people don't talk about it. I was stunned by how many women had received care for it when I
Yeah.
talked about it.
Yeah. So I think if I recall some numbers correctly, I think it's like 2 out of 3 women will experience some type of pelvic floor dysfunction throughout their lifetime.
Wow.
Could be even more than that. And that's not just urinary incontinence. I think it does cover most of that.
Mhm.
But I think, admittedly, I think it's far more than that. I think most people do have some pelvic floor dysfunction, but it affects everyone differently. So, maybe someone does have urinary incontinence, but it occurs like once a year randomly.
Right.
Where there are people that do have more chronic prevalent symptoms. But I think it's kind of around there. It's about 2 out of 3 women will have some type of pelvic floor issue.
That's a lot.
Yeah, it sure is.
And um, I, my mom never talked about it.
Sure.
And is this something that increases with age? One of the things that the urogynecologist told me is that our urethra as women is shorter, and because it's
Mhm.
shorter, it's more prone to prolapse or dropping. And so
Sure.
women, just because of our anatomy, are more likely to see this than the urinary incontinence than men are.
Sure.
So anatomy dictates some of it, but
Yeah.
what else can cause urinary incontinence and other pelvic floor issues?
Sure. I will say that aging is part of the piece of the puzzle.
Yay!
Yes. So, I mean, and that's not to say that, oh, of course, as you get older, you're going to have these problems. You just got to deal with it. I think there's so much assumption. This goes back to my reason why I'm doing what I do, is that we just think, oh, well, I'm getting older. So now this is how life is. I'm supposed to
Right.
leak. This is supposed to be happening. And we don't want that to be your norm. We want to help you not have that problem, but certainly it can develop. And there's a couple reasons why. So we can, of course, in our childbearing years, if we do have a history of having children, it doesn't matter if it was a vaginal birth or cesarean birth, we can have some change in muscles around our core that can, if not addressed after that birth, eventually kind of down the road, eventually catch up with us, if you will, and we
Yeah.
can start to have some problems later in life. So sometimes we can experience urinary incontinence or pelvic floor dysfunction after menopause. And that can happen around on the average age 52, but very different for each female. But the reason that menopause can have such an effect on pelvic floor dysfunction is we have that hormone shift, especially that drop in estrogen levels, and that actually changes our soft tissue support. So that affects our skin and how pliable our skin is, and our skin becomes more fragile. And that affects skeletal muscle tissue too. We become a little bit weaker, and we can have a little bit more muscle atrophy if we're not working on keeping ourselves strong. So if we couple the tissue, the lack of tissue support with the muscle weakness, if you maybe were having no problems before menopause and all of a sudden, bam, you're hit with menopause, those sudden changes can just weaken your muscles, create more lax tissues, and that means less support to something like your bladder, for example, and your urethra, and then all of a sudden you're leaking all the time, or you leak when you cough, or whatever the issue is. And of course, some of that can be mitigated by help from some hormone replacement therapy, and that could be something that you take orally or even topical. There are different things that you can do to address that too. And if no one has listened to the menopause episode with Dr. Pinkerton on this podcast, I'd recommend that, because I think that was really informative on things we can do to try to help address symptoms of menopause and how to work through that. Other than that, there are some other conditions that can affect our skeletal system. So people born with more hypermobile tissues, maybe they have something called Ehlers-Danlos syndrome, which is just a skeletal soft tissue disorder where we're very, very, very flexible. And that makes our muscles more likely to have to work harder, and or our tissues become more lax, and we can have something like less bladder support, and we can have more leakage throughout our lifespan as well. Sometimes we can also just have muscle dysfunction occur over time. So for example, I've been seeing a patient recently who has none of this history. She hasn't had children. She's not postmenopausal. She's young and healthy. And she's like, every time I cough, laugh, sneeze, I leak. And we found out it just because she's had a change in activity over time. So she's in medical school, she's sitting more, she's studying more, she's stressed. And that is contributing, I think, to just some muscle dysfunction, some muscle stiffness, some lack of movement. And we were able to help resolve her symptoms rather quickly by identifying kind of where her pitfalls just with change in her lifestyle for the past few years. So sometimes it's just some lifestyle issues, either with our diet, with our activity, with our hydration. And we try to help people identify where the lifestyle pitfalls as well.
I was on a webinar with Dr. Pinkerton and someone else from UVA, and it was one of those things where they were like talking about someone had asked, "Can you get rid of that menopause belly?" And Dr. Pinkerton said, "Well, cut down on your sugar, cut down on alcohol, exercise more, get stronger."
Sure.
And she started giving all these things, and we all kind of were sitting there, it was on Zoom, but I was texting with a friend at the same time, and we're like, so basically cut out everything fun.
Sure.
And someone actually said that, the moderator,
Yes.
actually, it was John Grisham's wife was the moderator, and she actually said that, and it very much was
That's
the case.
funny.
I was like, wow, like, is there
It really is how it
good
feels,
to look
yeah.
forward to? And of course, Dr. Pinkerton talked about how, at this point in our lives, so, like I said, I'm 50, I am menopausal right now. And there are good things that come about. You really do get to this point in your life where you're like, I like who I am. I'm good.
Sure.
I'm good with
Yeah.
who I am. I don't, when I was younger, I worried a lot about what other people thought and presenting
Sure.
myself in a certain way. And, I'm too much of all kinds of stuff. I'm too loud. I'm too independent. No, I am. I just own it. And now I own it. I'm like, if you don't like that, that's okay. But this is who I
Sure.
am, and I add
Yeah.
value.
Yeah.
So there are things about being menopausal. You don't have to worry about getting pregnant, like you don't have your period
Sure.
anymore. Like there are good things about it.
Yeah.
But I think you hear these things and you're like, crap, I get
Right.
older and I lose muscle mass and I
Right.
metabolize things more slowly, and now I start peeing on myself, like,
Right.
yay.
Uh-huh.
What is the hope that you can give to people that there are ways of making this better?
Yeah. Well, so kind of what we already talked about, that there are some lifestyle changes that we can sure make. And I realize that sometimes that means limiting some of the fun things, as you mentioned. But I think it's also important to recognize that we're not defined by our health issues or our health status. That's not what makes us who we are. That's part of us. But I think a lot of women can strongly identify, like, oh, I'm menopausal now. I'm, a lot of negative thoughts, whatever you can come up with. I know some people be like, oh, I'm just old and worn out now. And I'm like, no, this is just a change in life stage. And you have to learn how to find, like you mentioned, the positive in it. And I think that's important for a lot of things that we experience in life that are like just kind of stink or that we don't really appreciate is, okay, I'm going through this for a reason. What can I do to make this better? And I think some of that is kind of some self-advocacy and some self-exploration. And I think you can make that kind of fun and challenging. At least that's how I view it. Perhaps not everyone would like to view it that way. But I think it's really trying to put power in your own hands and take control of your life however you would like to. But really just realizing that you are a person, you are human. We go through human experiences, and menopause is one of those things for women. And it's, how can we better embrace that? And we kind of have to figure that out, I think, on our own a little bit with exploration. I'm also a very big advocate for mental health counseling too. Certainly, menopause can come with some mental health issues, like more depression. We don't sleep as well, a lot of other things. And I think it can even be important to talk about how menopause affects you as a person. So if you do have a lot of negative feelings, or you just feel like this isn't how life should be, this is terrible, now I can't enjoy all the fun things like my wine and whatever I had to eliminate, I think talking to someone about it, or that could be a support group as well, just to figure out how to work through those tough emotions, and how to cope with that and then come out better on the other side. I will say kind of one caution with support groups, make sure it is supportive and not just like a gripe fest and then walking out. You want to get something out of it that's positive and helpful.
I want to be sensitive to your time. And I always like to ask my guests, what if you could leave one piece of advice with our listeners here today, what would you say? And it can be about empowerment, it can be about owning your body, it can be really about anything, but what piece of advice would you give them?
Yeah. I would say being an advocate for yourself when something doesn't feel right. And I think that can be a common thing that we can experience with our bodies, where we feel like there's something that's not quite right. And we can see professionals, we can talk to people, and someone could be kind of dismissive or like, oh, you're probably fine. Or, like I mentioned earlier, all the tests are negative. There's nothing that shows up in your MRI or what have you. But if you feel in your heart of hearts something doesn't feel right to you, trust that gut instinct and keep pursuing the help until you find your answer. Sometimes that takes a long time. Sometimes that takes a lot of opinions. That can be a very emotional ride. So find your support wherever necessary. But I have found in treating pelvic floor dysfunctions, I have met a lot of women specifically who just feel like they weren't given the tools, the education, or the knowledge to take care of their bodies. And they know something isn't right, and they had no idea there was a solution, or they didn't know something was wrong until someone was like, you have this. And I thought that was normal my whole life to have this. So I think just recognizing that we have to fight for ourselves sometimes. And that can be a lonely journey, but it's one of the things where I try to support my patients in that journey is if I'm like, I don't have the answer either, but go see this person, go get this opinion. If they say no, what's the next avenue? So I think you have to really be able to fight for what you need in this life we have, and have that support where you can. And I would be one of those people to help support you.
I love that. I absolutely love that. And having worked in the healthcare space for most of my career, I am a firm believer in that. But I love hearing that. And so, Kim, you have been awesome, and I so appreciate you giving your time up to us today. I think women are going to listen to this and go, "Oh my gosh," it's just it's so important, and I am so grateful for your time. So thank you.
Yeah, you're welcome. And I really appreciate you inviting me on here and being able to share this. It's one of my favorite things to do, is to share the knowledge that I have about something that's very intimate and sensitive. And again, there's a knowledge gap. So let's fill that gap. And this is a way to do that.
Oh, that's perfect. That's perfect.
Yeah.
Thanks for joining us on the Queens of Moxie podcast. I hope that you found it inspirational and that it helps you to think about how you can step into joy and live your authentic life. And remember, we have a weekly email so that you don't miss any of these episodes. Plus, it starts your Monday out with an inspirational quote and a beautiful image. If you haven't subscribed yet, go to queensofmoxie.com and click on Weekly Inspiration. Thanks again for joining us, and we'll see you again next week.